Hello students. So today we are going to see about posterior teeth selection for complete denture prosthesis. So before we go on to the artificial dentition, let us just look into the difference between natural versus artificial dentition or the denture teeth. In natural dentition, the proprioception is primarily taken care of by the PDL, whereas in artificial dentition, there is no PDL. So only the mucosa receives the proprioception, and it is not as good as the natural tooth. When we bite with the natural dentition, the most common biting position or the favorable biting position is your molars. But you cannot do that same thing in your artificial dentition, as biting of the most posterior teeth can cause lifting of the denture or lifting of the anterior portion of the denture. When there is one tooth which is maloccluded, for example, there is supererosion of one teeth in a natural dentition, it doesn't affect the other side teeth. Whereas malocclusion in your artificial dentition, your denture teeth, will cause distability or instability of the denture on the opposite side also. Likewise, the artificial dentition moves as a whole. So the lower denture on both sides are connected. When one side there is a force on one side, the opposite side gets affected, which is not the case in natural dentition. And the most common type of occlusal scheme or the preferred occlusal scheme in natural dentition is the canine protected occlusion or the group function occlusion, whereas in your artificial dentition we prefer a bilateral balance occlusion. So bilateral balance is only artificial and it is not present in natural dentition. So what are the requirements of a complete denture occlusion? The first requirement of occlusion is to provide stability, and that is the purpose we are giving bilateral balanced articulation. So stability means the dentition has to control the buccolingual forces acting on the denture. So the lever balance is achieved by a favorable ridge to tooth position, which means the teeth should not be placed too far away from the ridge, which will create a vertical cantilever or which will destabilize the dentures. The other functional components of the denture requirements of the denture teeth include the cutting and penetrating action of the teeth. Also, the anterior incisal teeth help in incising the food, and it also helps in clearing the food from the incisors. The posterior occlusion is aimed at reducing the forces of mastication. That is why we try to place the center, try to place the teeth in the center of the ridge rather than away from the ridge. And balance occlusion or balanced articulation, as I told you before, exists only in your artificial dentition and it is not a part of natural dentition. So what are the types of posterior denture teeth? Before that, we will just go into the basic terminologies. The cusp angle refers to the angle which is made by the slope of each cusp with the horizontal plane. So depending on the cusp angle, we can divide the teeth into anatomic, semi-anatomic or non-anatomic teeth. Anatomic teeth are teeth which have a cuspal angle of 33 degrees or more, whereas semi-anatomic teeth have a cuspal angle of 20 to 30 degrees, and non-anatomic teeth do not have any cusps at all. They are relatively flat teeth, or they are called monoplane teeth. So this picture, the first shows anatomic teeth with very prominent cusp form. Semi-anatomic teeth, which are more commonly used by the students, have shallow cusps, and non-anatomic teeth or monoplane teeth have flat cusps. Now let us see what are the different types of posterior tooth forms which are used in complete denture fabrication. First, let us see the anatomic teeth. As I told you before, the anatomic teeth have a 33-degree or more, and they are more, they look more like a natural dentition. The first anatomic teeth was introduced by Alfred Geisy, and they are called as true bite teeth, and they have a cusp angle of around 33 degrees. So this tooth was marketed by the company in 1914, and they closely resemble the natural dentition. So they had transfers they had transfer ridges and were intended for tight interdigitation in class 1 occlusion. So this is Dr. Alfred Geisy, and these are the teeth which were created, or the true bite teeth which were initially marketed by Geisy. The next type of anatomic teeth is the Pilkington-Turner teeth. So they had a shallower cusp, relatively shallow compared to the Geisy's teeth. Whereas instead of true interdigitation or tight interdigitation, these teeth provided some amount of freedom in protrusive excursions, but they were tightly interlocked in lateral excursions. So this is the diagram of your Pilkington-Turner teeth. Semi-anatomic teeth are teeth which are less than 30 degrees or range from 20 to 30 degree. So again, Alfred Geisy introduced the crossbite posterior. So this crossbite posterior is also the primitive or the precursor for the occlusal scheme called as the lingualized occlusal scheme, as these occlusal surfaces had a motor and pestle action. So in this, the maxillary buccal cusp was almost eliminated. Therefore, only the palatal cusp came into contact with the lingual fossa of the mandibular teeth. So this is how the cusp articulated with the mandible. You can see that there was no buccal cusp in the maxilla and only the palatal cusp articulated. So this made the forces more centralized over the ridges, and it was easy for the dentist to balance these teeth. It resulted in better stability. The next semi-anatomic teeth was introduced by Victor Sears, or channel teeth. These are basically like there is a lower channel or a lower upper groove, and the lower teeth are scissor shape and go and sit inside the channel in the maxilla. So because of this, they are called as channel type of teeth. The next type of teeth were the scissor bite teeth. In this, the posterior occlusal surfaces were locked anterior posteriorly by grinding steps on the surface of the teeth. The angle of the teeth were determined by the inclination of the condylar path or the horizontal condylar guidance. They were free to be modified in lateral excursion. So it looks like this. If you look at the teeth cusp look like the tooth of a scissors, and that's why it's called scissor bite teeth. And this angle of the tooth cusp was parallel to the horizontal condylar guidance. French's modified posterior, the mandibular teeth had a narrow mesiodistal foot table. This is actually somewhat opposite to the lingualized occlusal scheme, whereas where only the mandibular buccal cusp came into contact with the maxillary plane. So the maxillary teeth were typically flat, whereas the mandibular teeth had only one point of contact, that is on the buccal cusp. Non-anatomic teeth are flat teeth which are used, and they are specifically used in situations where there is no where there is a poor ridge form, or where there is no possibility of using an anatomic or semi-anatomic teeth. So one of the first teeth was called as the Hall's inverted cusp tooth. So it was introduced by Hall in 1929. So this presented with concave surfaces on the occlusal surface. So it is like this. It looks like the flat teeth with inverted cusp, which means the cusp is going inside the tooth. That is why these are called inverted cuspal teeth. Next is the Nelson chopping block teeth, in which there were flat occlusal surfaces with numerous ridges. The ridges were primarily intended to improve the chewing efficiency. So this is how the teeth were. The teeth are flat, but they had either buccolingual or mesiodistal grooves on the occlusal surfaces, which improved the chewing efficiency. And this particular question comes as a short note for you, so be specific, or you can answer this as a short note. These are called Hardy's Vitalium occlusal teeth. You can see that in the posteriors, though the posterior teeth were flat, there was a insert. These are called Vitalium inserts or cobalt chromium inserts, which are placed on the occlusal surfaces of the teeth. And the intention of placing this on the occlusal surface is to provide better masticatory efficiency. So when this question comes as a short note, you can just mention this as a modification or a type of flat or a non-anatomic, sorry, a monoplane teeth, and it was introduced by Hardy. And the function of this is to improve the masticatory efficiency. Please do include a diagram for this question. So the factors that determine the posterior teeth selection include the neuromuscular control, which means patients who are having very poor neuromuscular control cannot be given anatomic teeth or semi-anatomic teeth. So in these cases, we go for monoplane teeth. Same is the situation where we are not able to record a proper jaw relationship. For example, patients in whom we cannot record a tentative jaw relation or obtain a proper bite, we use a flat plane teeth. The aesthetics are better in anatomic teeth. So patients who want better aesthetic, we can go for anatomic teeth. Same, the chewing function and efficiency is better with anatomic teeth. So these type of anatomic teeth are more preferable in cases of a prominent ridge form. If the ridge form is not good, better do not go for anatomic teeth. And we also choose the teeth depending on the ease of balancing. So to sum it up, when the ridge form is prominent, go for anatomic teeth. When the ridge form is average, go for semi-anatomic teeth. In case of flabby ridges, go for non-anatomic teeth. So that sums up the discussion on posterior tooth forms. Thank you.